The fibular head.
It's here.
The common peroneal nerve.
That runs down and branches off from there.
The peroneus longus muscle.
Starts there and will come down posterior to the malleolus and connect on the first cuneiform and first metatarsal.
The peroneus brevis muscle.
That'll be distally, running posterior again and to the base of the fifth metatarsal.
The fibular shaft.
That's palpable along the bone down through here.
The lateral malleolus.
And that will end right here, lateral malleolus.
The peroneal tubercle.
It's right here.
The calcaneofibular ligament.
Here.
The anterior talofibular ligament.
That'll be running here, connecting to the talus.
The posterior talofibular ligament.
That wraps around and connects to the talus.
The anterior tibiofibular ligament.
That connects the tib and the fib in the front.
The posterior tibiofibular ligament.
Same thing, connecting the tib and the fib in the back.
The peroneus tertius.
That will start distally again, run anteriorly, and connect on the shaft of the fifth metatarsal.
The tibial tuberosity.
Right here.
Gerdy's tubercle.
That's lateral to it for the connection of the IT band.
Anterior tibial shaft.
Right here, that shin bone will be the shaft of that.
Anterior tibialis muscle.
That's this muscle right in here.
Extensor hallucis longus.
Can you extend your toe? And that's going to come right next to that.
The extensor digitorum longus.
Extend your toes. Those come up right next to the hallucis, lateral to it.
The extensor retinaculum.
The superior one is above the tib-fib joint, and then the inferior one is lower in the midfoot.
The dome of the talus.
Invert. Right here.
The sinus tarsi.
This depression right here.
The medial malleolus.
Right here.
The deltoid ligament.
Those will be in a triangle around there.
The sustentaculum tali.
Right there.
The tibialis posterior muscle.
The tendon will come down through here, and that goes up deep to the gastrocnemius complex.
The flexor digitorum longus muscle.
That will come posteriorly, posterior to the medial malleolus, and was that hallucis or digitorum?
Digitorum.
And then that will come under the plantar surface and connect to toes 2 through 5.
The flexor hallucis longus.
Same thing, posterior medial malleolus, plantar surface to the hallucis.
The gastrocnemius soleus complex.
That's this muscle here.
The Achilles tendon.
This tendon back here.
The subcutaneous calcaneal bursa.
That can be found between the skin and the Achilles.
The subtendinous calcaneal bursa.
That is between the Achilles tendon and the calcaneus.
And calcaneus.
This bone back on your heel bone. Okay, now I'm going to go into active range of motion. I'll have you slide forward with your legs off the table. So for this, I'll stabilize. Can you push down on the gas pedal? That's plantar flexion. Can you push up with your foot? Dorsal flexion. Turn it inward, inversion, and outward. That's eversion. Okay. Now I'm going to do some goniometer measurements, starting with plantar and dorsal, so I'm gonna be on the lateral side, stationary arm up the fibula and the fulcrum on the malleolus, with lining up on the 5th metatarsal. Okay, she's in neutral. I'll have you push down on the gas pedal. Take that off. That's about 50, which that's normal. I'll do that same positioning again. And I'll have you lift up. 20, which is normal. Now I'll do inversion, eversion with the fulcrum on like the joint there, and this going up the tibia, and this on the movement arm on the like the 2nd metatarsal. So I'll have you invert your foot. Okay, that is 20, which is normal. And then I'll have you evert. That's 5, which is also normal. Okay, next I will do some passive range of motion. I will have you slide back and lay down supine. Hard to record. First, I'm going to start with plantar flexion, stabilize, and I'm going to push, plantar flexion, and then dorsal flexion. With those, end feels are firm, which is good. For the 2nd dorsal flexion, I'm gonna have you put your heel on the edge of the table, and I'm going to push up, firm, which is good. Have you extend again, and then inversion, firm, eversion, firm, which is all good with those. And for all of these, including goniometer, I would be testing bilaterally, active range of motion bilaterally as well. Next, I'll do manual muscle testing, so I'll have you sit up with your knees extended. First, I'll have you push down on the gas pedal. That's good, 5 out of 5. And then slide forward and with your knee off, flex. And then do it again, push. That's good, 5 out of 5. Slide back again. Push inward, invert your foot. Good, 5 out of 5. And evert, good, 5 out of 5. Same thing, I'd be comparing bilaterally there. Next, I will go into special test. I'll have you slide forward again. First test I'm going to be doing is the anterior drawer. So I'm gonna hold her foot here. With this, if there was any pain or sliding, clunking, that would be the talus sliding anteriorly, and that could indicate an ATFL sprain. Next, I'm going to do Kliegers. So I'm going to dorsal flex and externally rotate. And then pain with this would indicate syndesmosis, which is a high ankle sprain. And then I'm going to do POTS, which I'm squeezing along here. And then if there's pain down here towards the tib-fib connection, that is syndesmosis as well, or high ankle sprain, and pain up here would be a fracture. Next, I'm going to do the Taylor tilt, inversion and eversion. So first I'm going to do inversion, and if there was excessive lateral gapping or pain, that would be damage of the CFL. And then eversion, if there's excessive medial gapping or pain, that would be a deltoid ligament damage. Next, I'll do the bump test. So I'll have it dorsal flex and striking the calcaneus, And if there's pain emanating from there, that could be a stress fracture of the tib, fib, talus, or calcaneus. Next, I will do the Heins, which is dorsal flexion, knee extension. So if there was pain in the calf, that would be deep vein thrombosis or a blood clot. And last, I will do a Thompson. So I'll have the patient lay on her stomach. For this one, I will squeeze the calf, and if the foot does not plantar flex, which it is in this, but if it doesn't, that would indicate an Achilles tendon rupture. Now I'll go on to neurovascular testing, starting with our 2 pulses. First, dorsal pedis pulse. Right there it is. And then posterior tib. Posterior tib over here. And right there it is. Next I'll do myotomes and dermatomes. Starting now with the dermatomes. For L4, I would ask my patient to close their eyes and distinguish the pain, the feeling sharp or dull. For L4, sharp, dull, they tell me. Dermatome L5, sharp, dull between that web space, sharp, dull. S1, peroneal region, sharp, dull, S2 is plantar surface of the calf, sharp, dull, same thing. Now for the myotomes of those, for L4 is ankle dorsal flexion, so I'll have the patient bring their ankle up. Good. And now L5 is toe extension. I'll have you bring your toe up, your big toe, just your big toe extension. And then S1 is ankle plantar flexion, so step on the gas pedal. And then S2 is knee flexion, so I'll have you slide your knee back and flex it. Yep. And then for these as well, there's reflex testing for L4 patella. There it went. Same thing with L5, so L5 and L4. And then S1 and S2 are both the Achilles, so movement there. For special tests and neurovascular, obviously, like I said, bilateral. If they didn't fire on one side, that could mean there's problems with the neuron there, a lesion in it. And so that was for S1 and S2. That's all.